talk about VA-ECMO today. I gave a talk on VA-ECMO this time last year. So if anyone has any specific questions on VV, feel free to review that one. We're going to review some of the same things just briefly that's similar between the two, but mostly talking specific to VA-ECMO. I have no disclosures to report, but just keep in mind I am no ECMO consultant, but have some interest in ECMO. Our learning objectives today are to identify the indications and contraindications for VA-ECMO, describe the key components of the ECMO circuit, be able to compare VA-ECMO to VV-ECMO, describe the hemodynamic principles involved in VA-ECMO management, understand competitive flow and differential oxygenation, list the causes of cardiac arrest for patients on VA-ECMO, and recognize when a patient can come off of VA-ECMO. So first, we're going to go through the indications, contraindications, SCAI stages, and circuit tour of the VA-ECMO circuit. But first, what is VA-ECMO? You may ask yourself. It is veno-arterial extracorporeal membrane oxygenation. Here's a picture of a patient in the ICU cannulated to ECMO on the right there. You can see the whole circuit and pump and tubing, and obviously a lot of drips there attached to the patient. The indication for VA-ECMO is refractory cardiogenic shock. Ideally, VA-ECMO is given or offered to patients within 6 hours or more potentially of refractory cardiogenic shock. And by refractory, I mean that it's refractory to conventional pharmacologic and fluid therapy. And it's for patients who are eligible for more advanced devices. It's not an end-stage treatment for patients. Over 2,000 patients a year are cannulated for VA-ECMO in the US. This is up from about 20 adult patients 20 years ago. So VA-ECMO is being increasingly utilized as our technology gets better. There's improvement overall in percutaneous cannulation techniques, pumps, oxygenators, and the cannula themselves that have made ECMO a more viable option for bridging to transplant, LVAD, or TAH. Compared to mechanical circulatory support systems, ECMO patients might do better in the setting of malignant arrhythmias, as well as if they also have associated pulmonary failure, though there's still being data gathered between MCS and ECMO therapies. ECMO is ideally considered when medical treatment is refractory, as I mentioned, and oftentimes is used after an intra-aortic balloon pump fails. There's a certain number of scores that are utilized to determine patient survival, and essentially it depends on someone's pre-ECMO status. For patients who have different comorbidities, the survival to discharge ranges anywhere from 18 to 75%. And there's different scores that are utilized to determine someone's likelihood of survival. These include the SAVE score, the ENCOURAGE score, REMEMBER, and CARD-SHOCK score. These are all variable. But this also is in the setting of being selective in the patients that we are picking for VA-ECMO. The Extracorporeal Life Support Organization is an international organization that overall keeps track of how patients do on VA-ECMO and has the best data following ECMO patients. When you're thinking about ECMO or you're seeing a patient in cardiogenic shock, you should keep in mind the SCAI classification or SCAI stages of cardiogenic shock. This was a new system to me as of last year or 2 years ago, and came out in 2019 as a consensus statement from the American College of Cardiology, the American Heart Association, the Society of Critical Care Medicine, and the Society of Thoracic Surgeons. And it's meant to have a framework for everyone to essentially recognize when someone is going into refractory or deteriorating cardiogenic shock. SCAI stands for the Society of Cardiovascular Angiography and Interventions, And it goes from A, B, C, D to E. And ideally, we recognize patients in the C classification, which if you can look very small in there, it mentions that that's when patients might be considered for ECMO. We often see patients at the A stage, which is considered the at-risk stage, when patients might be having heart failure, they might be in the early stages of becoming cold in the B stage, showing stages of hypoperfusion with elevated lactates. But when patients are becoming refractory to our usual interventions in the C stage is when you should consider VA-ECMO or other support devices. Patients who are in the D or E stages, deteriorating in extremis, are usually probably past the point of ECMO consideration, but potentially, depending on their functional status and what's going on, D could be considered potentially. Extremis is usually, though, considered an end stage of cardiogenic shock. So reviewing the indications for VA-ECMO, again, it's for reversible cardiogenic shock. VA-ECMO is not a destination or an end therapy for cardiogenic shock. It's most commonly used for acute severe heart failure. It can also be used for myocarditis, cardiotoxic drug overdoses, a myocardial infarction, severe hypothermia, and a massive pulmonary embolism. Contraindications are severe multi-organ failure, severe neurologic injury, irreversible heart failure, a terminal disease such as cancer, advanced age, which is subjective based on the center that's offering ECMO, severe aortic insufficiency, unrepaired abdominal aortic aneurysm, and an inability to tolerate anticoagulation, as systemic anticoagulation has to be provided in the VA-ECMO circuit to prevent clot and stroke. Let's look quickly here at the ECMO circuit and the cannulation. This is the typical peripheral cannulation. So venous deoxygenated blood here is drained from the IVC. You can see this in the blue tubing here, and comes out through the femoral vein. Oxygenated blood then flows through the femoral artery. And this is it was certainly something unusual to me when I first was reviewing how the ECMO circuit works, because blood is flowing in the reverse of our typical fashion of our native heart function. The oxygenated blood is flowing up through the aorta towards the heart. And we'll review some complications that can happen with this. But your ECMO circuit is providing that oxygenated blood to both the lower extremities and the upper extremities and brain and heart in this fashion. This is different from VV or veno-venous ECMO, which is used for lung failure, where oxygenated blood is supplied through the jugular vein, and it is supplied to the right atrium, where this is then pumped through by the heart, because the heart is thought to be functional, and then it is drained via the IVC. The only real main differences between VA and VV ECMO in terms of their settings and management is that VA ECMO requires anticoagulation because of its setting in the arterial system. However, management in terms of temperature, the sweep gas, vent settings are all largely similar, though sometimes we use different vent settings for very sick patients. Here's just a comparison of the two systems so you can see them directly side by side. We'll do a quick tour here of the ECMO circuit itself. The first part of the system is the venous cannula. This removes deoxygenated blood from the right atrium. It has a venous bubble detector on it. It also has a pressure measurement cable and a hemoglobin probe as well. This is the ECMO pump. It's a centrifugal pump. It's rotating constantly, providing flow to the body. This is the gas exchange device. It has a sweep gas inflow, which uses compressed wall oxygen, compressed wall air, and blends the two together to deliver the desired amount of oxygen. It also has a flow meter. It has a heat exchanger, and it has access points for sampling blood or removing air if air gets trapped in the circuit. This is the sweep gas blender here. This removes CO2. And this is the arterial cannula, which also contains a bubble detector as well as a flow probe to assess the amount of oxygenated blood that is being supplied to the body. Next, let's talk about some hemodynamic principles of the circuit. These include right ventricular and left ventricular offloading. We'll talk a little bit about MAP and considerations in terms of ECMO management, competitive flow, and differential hypoxemia. So first, let's talk about RV and LV offloading. The goal with VA-ECMO is that it achieves ventricular decompression. This is both RV and LV decompression. It also maintains forward flow of blood because in a severely dilated or in severe biventricular heart failure, flow is not adequate, resulting in cardiogenic shock. And it also helps maintain a perfusing mean arterial pressure. So let's look at this video here of a dilated heart that's in severe biventricular heart failure. You can see that both the left ventricle and the right ventricle are severely dilated. And if you were to guess that their mean arterial pressure was low and their CVP was very high, you would be correct. So this patient does not have a perfusing MAP, and they're in cardiogenic shock. So let's recall that the mean arterial pressure is essentially hemodynamically thought of as blood flow times systemic vascular resistance with the addition of the right atrial pressure. Right atrial pressure is thought to be essentially the amount of blood volume that we can modify by diuresis. And our surrogate measure or direct measure of right atrial pressure is the central venous pressure, which we can directly have a hookup to measure this when we have patients on ECMO or in patients in the ICU. Systemic vascular resistance can be augmented by vasopressors, which can improve our MAP, but we can also use vasodilators if we need to reduce afterload on the left ventricle. This is important because when we initiate ECMO flow, we need to essentially make sure that we have a perfusing MAP and need to adjust patients with vasopressors, diuretics, or vasodilators accordingly. So when we cannulate someone for ECMO, we essentially need to think of the RV and the LV and how we are offloading them to help maintain forward flow. The venous cannula offloads the RV, which drains right atrial blood. The arterial cannula, however, can increase LV afterload, which can increase LV distension. Even though we are thinking of VA-ECMO overall helping the heart, so we have to keep in mind that although we are pushing oxygenated blood back up the aorta towards the heart, this can worsen left ventricular afterload due to the pressures. So let's look at this echo of this patient who's been cannulated for ECMO. This is the same patient as before. And you can see in the short clip, they do have a little bit more squeeze. They're a little bit less dilated and overall have a little bit more forward flow. We essentially like to keep track of how well someone does have forward flow by watching their pulse pressure. If we have a pulse pressure greater than 10 millimeters of mercury, we can adequately say that a patient has good enough forward flow. We also use serial echo as well to assess patients' forward flow and see if their EF is able to improve. Sometimes, however, because we cannulate patients for ECMO and increase their afterload with arterial blood being supplied up the aorta, we need additional measures to offload the left ventricle. So sometimes we need additional devices in place to help out the heart. One such device is an Impella, or a percutaneous microaxial pump. This is placed into the left ventricle and is a tube that is pumping blood directly out of the left ventricle. These can be placed percutaneously or surgically. And you can see here the pump is in the left ventricle going out the aorta, supplying blood to the rest of the body. There's a few other strategies for offloading the left ventricle if it's not able to maintain a perfusing map. This includes an atrial septostomy or other unloading strategies. These are interventional strategies that essentially help just shunt blood away from the other side of the aorta so that the left ventricle can help push blood forward. These are more advanced options and in severe situations of high afterload. Because the arterial cannula is supplying blood up the aorta, and the native heart is supplying blood also into the aorta via the aortic valve, there's a point in the body where there is a mixing point. This is usually in the proximal aorta. And when we initially cannulate someone for ECMO, we usually think of the native heart, because it's in such severe shock, providing about 20% of cardiac output to the body. The ECMO circuit provides about 80% of the rest of cardiac output to the body. Because when we cannulate patients for ECMO, their cardiac output is so low and they're in cardiogenic shock, the ECMO circuit, essentially, you can think of it outcompeting the heart, and the mixing point is high in the aorta, close to the heart. And so the coronaries are perfused, the upper extremities are perfused, the brain is perfused, and the whole body is perfused because blood is also supplying the lower extremities as well. However, when cardiac output increases and the heart starts to recover, the mixing point moves. Depending on the ability of the lungs to provide oxygen, this may result in hypoxemia or may not. Differential oxygenation is the issue when the native heart starts to recover in its function and pushes this mixing point down the aorta. This only becomes a problem if there's a shunt in the lungs that's providing deoxygenated blood to the heart. If the heart is pumping oxygenated blood from the lungs and the lungs are being ventilated and oxygenated adequately, this is not an issue. However, if there's concomitant ARDS or other problems in the lungs that are providing deoxygenated blood to the left side of the heart, this results in differential oxygenation. This is also known as north-south syndrome, which you might have heard of. The reason that we monitor right upper extremities gases in patients on VA-ECMO is because of this phenomenon. Because the first place to start seeing low oxygen levels, if this mixing point is to move down the aorta, would be the right upper extremity, because it's essentially thought of as a watershed area where it's first going to see low oxygen levels. If this starts to happen, we can try and increase ECMO flow to outcompete the heart. We can also consider switching to VA-ECMO, which is a form of hybrid VA and VV ECMO. Or we can consider even coming off of VA-ECMO itself and switching to VV ECMO if lung failure is essentially the main problem now. This, again, rarely occurs when you first start someone on VA-ECMO because the cardiac output from the native heart is so low. So this only happens when the heart is starting to recover and is getting deoxygenated blood from the lungs. All right, let's move on to some complications, talk briefly about cardiac arrest, decannulation, and weaning. There are quite a few complications that can happen on the VA-ECMO circuit. These include circuit clot, though we try to prevent this with systemic anticoagulation. And again, if someone cannot tolerate systemic anticoagulation, this is an absolute contraindication to being cannulated for VA-ECMO because circuit clot can be catastrophic. Hemolysis is also present because of flow through the circuit and through the tubing and cannula. Cannulation site bleeding can be significant because you're accessing an arterial system. Cardiac tamponade can happen if there's complications. Pulmonary hemorrhage can also occur. CNS hemorrhage can also occur in the setting of anticoagulation. Stroke can also occur. Renal failure, sometimes related to hemolysis and pigment nephropathy. Infection can happen as well, and as well as limb ischemia related to the placement of the cannula. Of note, I think it's also important to acknowledge that the ECMO requires significant financial resources, personnel resources, including a bedside nurse, a perfusionist, respiratory therapists. And oftentimes we need to discuss futility and ethical considerations in these patients. This is such a high resource tool for managing patients with refractory cardiogenic shock that ideally we have these conversations in terms of what the ultimate goal is with VA-ECMO before we cannulate someone for ECMO. But sometimes someone does not become a candidate for a heart transplant or a VAD due to complications that occur or the natural trajectory of cardiogenic shock when someone is on VA-ECMO. So these can be difficult discussions to talk about potentially weaning off ECMO or not bridging to a destination therapy. I'll touch briefly here on cardiac arrest, since we do run codes at Montlake and at Harborview, which occasionally has the VA-ECMO patient. When you do get a code, if you do go to a patient on VA-ECMO, which is often rare because they often are managed just by the bedside team quite quickly, you do want to assess the normal causes for cardiac arrest, which can be the usual causes like a pulmonary embolism, electrolyte problems, VT, VF. Think of your usual H's and T's. But you also need to think about ECMO causes, because we try to think of both the patient and the ECMO as two different systems that can result in problems. So you have to think about membrane lung failure, which can happen due to clot burden that builds up in the lungs over time. This usually takes quite a bit of time to build up, but can also happen if there's just a problem with the membrane lung itself. There can be also a heater or cooler malfunction in the circuit. There can be severe circuit hemolysis resulting in DIC. There can also be significant bleeding, and there can also be an air embolism that can get trapped into the circuit or even move into the patient body. So these are something to consider if you get called to a code for a patient who's on VA-ECMO. The difference, though, for patients who are on ECMO who do have a cardiac arrest is that we don't need to do chest compressions unless there is inadequate flow. As long as blood is continuing to flow and there is an adequate map, we don't need to provide chest compressions because the ECMO circuit is providing flow through the body. So assess a patient's map and look at them with an ultrasound. And if they are having adequate flow through the body, oxygenating and having a perfusing pressure, then we don't need to initiate chest compressions. Some of the complications that can happen can result in the need to urgently take someone off of VA-ECMO. These include accidental decannulation, which can happen, say, if a patient awakens from sedation, accidentally pulls a cannula, which is rare. If there's a catastrophic clot, if there's pump failure, if there's air entrapment, or sometimes or rarely circuit rupture. If this does happen, there's a specific process that the bedside nurses and perfusionists have for removing someone from ECMO. They clamp the cannula to prevent hemorrhage. They stop the ECMO pump, and they initiate rescue settings. And these rescue support includes increasing vasoactive support quite quickly and implementing rescue vent settings if they're not already on rescue vent settings. So it's time to consider decannulation for patients when their native cardiac function is overall improving. This is often evidence based on serial TTEs or echoes. You may also see this because patients are needing less vasoactive medication doses. You may also see that they have improving organ function overall, indicating that they are providing perfusing pressure to their organs. And that you might even see differential oxygenation, meaning that the heart is competing more against the ECMO pump. And so this may happen with or without hypoxemia based on if the lungs are adequately providing oxygen to the left side of the heart. Some studies suggest that we should consider decannulation in 5 to 7 days once someone is cannulated for VA-ECMO, if they're not being considered for, if they're not going straight to VAD, or should consider 5 to 7 days as a way to get to VAD or transplant, but this isn't a hard and fast rule. This is the same echo from the patient that we saw earlier, and this is them when they were ready to decannulate. You can see quite a bit of improvement in their biventricular function. The steps to decannulation are variable across different institutions. However, they're similar in that we monitor pulse oximetry, we monitor the blood gas on the right upper extremity, because again, this is the first area to experience a watershed if there's inadequate oxygenated blood being provided by the native heart. We generally reduce afterload to help the LV out. We optimize contractility with medications as need be. And the main difference is between facilities in decannulating patients from VA-ECMO is how quickly we reduce the flow. Sometimes people will reduce it rapidly over hours or even minutes at times, or gradually over the course of the day. When we're doing this, we want to monitor patients' vitals, watch their pulse pressure, make sure that they have an adequate pulse pressure, indicating that the heart has good contractility, and monitor flow through the heart with serial echoes. And these echoes are being done at the bedside, maybe every 30 minutes or hour. A successful weaning is usually predicted by an ejection fraction of greater than 25%, though this isn't an absolute rule. All righty. Well, to summarize, we went through the indications and contraindications for VA-ECMO. It's for patients with refractory cardiogenic shock. We went through the key components of the ECMO circuit, which involves the return cannula, the pump, the gas exchange device, the sweep gas blender, and the arterial cannula. We compared the VA-ECMO circuit to the VV-ECMO circuit. They're similar circuits, but in different locations, providing oxygenated blood in the setting of heart or lung failure. We talked a little bit about the hemodynamic principles, and that the key principles in management include offloading the RV, offloading the LV, and maintaining a perfusing map. We talked about a little about competitive flow and differential oxygenation, that the idea of competitive flow is that oxygenated blood mixes with deoxygenated blood from the failing heart, which can result in differential oxygenation. We discuss some of the causes of cardiac arrest for patients on VA-ECMO, and that when a patient does arrest on VA-ECMO, we need to consider the native heart causes as well as ECMO circuit causes. And finally, we talked a little bit about weaning, when patients can be decannulated, which is when they usually show improvement in their ejection fraction and are needing less hemodynamic support. I want to thank my mentor, Janelle Badulak, and also give you guys some resources if you want to learn more about VA-ECMO. Core ECMO is Janelle's website that details VA and VV ECMO management and physiology. There's also data, studies, and guidelines published on the ELSO website, and ATS also has some videos and information on ECMO management. Thank you all for listening, and that's all I have today.
Wonderful, Sylvia. Thanks so much. Maybe let's give a minute or two if anybody has any follow-up questions. And otherwise, folks, I think beyond questions, we're all done for the day. Oh, some stuff popping into the chat. Let's see. Austin says, what are vent rescue settings? Could you ask someone to put them on rescue settings, or would you need to give specific directions?
Usually there's specific settings or guidelines for the bedside nurse and perfusionist. It's usually a rate of 10, a PEEP of 10. Ultra protective settings include 4 cc's per kilogram, and then we'll start at oftentimes 40% FiO2, but obviously increase if need be to 100% FiO2. But otherwise, it's usually a rate of 10, PEEP of 10, 6 cc's per kilo, and then FiO2 starting at 40% to higher if need be.
All right. Well, if no one else has last lingering questions, we'll let you all go for the rest of the morning. Yes, I agree with John. Stay warm, everybody. Stay safe if we have freezing rain, as we're maybe potentially supposed to have. We'll see you all next week for our last academic half day of the month.
Kayla, is that your home office?
This is not, I'm actually at my in-laws' house in Chicago.
Okay, good.
So I'm
I was
in
gonna
the
say,
basement.
I don't think I recognize that room.
No, but you did, you missed that I don't have him with me right now. I'm in the basement because we're staying in the basement because we just got a puppy yesterday.
Oh no,
A
yay.
Christmas puppy. So I'm sure the puppy will make a cameo next week as well, especially because we're doing a wellness thing next week. So
Awesome.
definitely.
Awesome. Are you I am going to be traveling at that time, and so you guys have it covered, right?
Yeah, I'll be there, and I think that Sarah and Lindsay are both planning to attend as well.
Okay. I will try to hop on, but I'm at my in-laws too, and I don't I've shared this joke with many, and I love my in-laws, but they're a little bit like that scene in the movie When Harry Met Sally. I don't know if you saw it, but Harry says to Sally, "You're the worst kind. You're high maintenance, but you think you're low maintenance." Those are my in-laws.
I know that feeling intimately. Yes.
All right. If I don't
No
see you,
worries.
have a great week.
You too.
Bye-bye.
Take care.